Series Part 2, Keeping Your Money. We're going to wait for a couple more minutes. We still see people joining, so we'll be back to you in just a few. Thanks. Nick, welcoming you to Boosting Your Bottom Line. Bag of Money Series Part 2, Keeping Your Money. We're just going to wait one more minute, and then we'll get started.
They'll introduce themselves as they come online here, and we'll go through the presentation. And again, this builds upon the Part 1 that we did a couple of weeks ago, and we have 2 additional parts to come, which will be after New Year's. So let's get started. So today, again, the agenda is introductions, as we just did. We're going to talk about how to keep your money, specifically focusing on reports and strategies you need. And, of course, we'll leave some time for questions and hopefully answers. All right. But before we jump into the series, just some of the housekeeping basic rules. Again, this presentation will be posted on the CTAC website. We're also going to later show you a spreadsheet and a tool that we have developed, and we'll go through it. And so that will be posted as well on our website together with this presentation, as well as this recording of this presentation. So you can definitely share this with your colleagues as we develop. And again, today's goal is to discuss on how do you keep your money. So some of the most popular kind of reports that we'll talk today a little bit about, and and as you probably have seen before and heard before, but we really want to tie this into some of the discussions we already had. And of course, are the denial reports, the age receivable report, do not build, and we'll talk more about what that means. The error and suspended reports, and not used. So what we really want to break down is for agencies to really focus on these 5 big areas as it relates to billing and claims and collecting money and keeping your money as you progress through this kind of a process here. And we'll go more into depth about each one of them and kind of define them and talk through these reports. Okay, so those reports fit nicely and are really part of what is typically referred to, and you've heard me and David and others talk about something called revenue cycle management. So, for some of you, this might be just a refresher. But for others, we want to, keep it, maybe it's new. I am hearing, so let me just pause for a minute. We got a couple of comments that there seems to be some feedback on the call and maybe some repeating. So let me just stop there for a moment because I just want to make sure folks can hear me. So if others can chat in, again, that's how we're going to do our questions as well, through a chat box. It's on your right-hand side, and if you can send it to all panelists, that would be great. But I just want to make sure that, folks can hear me correctly and that we don't have feedback going. Okay, so I think now we're getting a message that the sound seems to be okay, so I'm glad that that kind of worked out. Again, so coming back to the presentation, so the revenue cycle management, it really has the components of the entire, the cycle here, just quickly going through it. It's through the kind of the scheduling, pre-registration, registration process. There's the charge capturing and coding, and again, we'll go through each one of them in more detail. There's the claim submission. There's the payer follow-up after you submitted the claims. There's the remittance process, and then there's, of course, appeals, collections, and analysis as we go through it. On the left-hand side, it's again, we have a visual here as a graph We have words. We know some people are more visual. Some people, are more word folks. So we have it both. And again, within the revenue cycle management, it's very important to also realize that the contracting piece, the quality assurance, the utilization review, credentialing, and regulatory compliance are all part of it. A lot of times, and unfortunately, I hear things like, well, billing and finance and all that stuff, especially billing and claiming, it's part, my finance department takes care of it, or my billing department takes care of it. And I think what we want to emphasize today and really talk about, that it is not just the finance department, it is not just the billing department, it is really the responsibility of all within the program, within the clinic. Because again, the individual who does the scheduling, the registration or pre-registration, if they make any mistakes, that ends up on a claim. That ends up as a potential denial or something that doesn't get out the door. If the individual who provides the service is not putting in the right charge or code, that creates problems, right? If the submission of the claims has some hiccup in it, and so everywhere through this process there could be a potential issue or concern. So it's important that everybody involved realize how they play a role in this and how important it is that they do it the right way and correctly from day one. And from the initial setup and submission, because as we all know, to fix the mistake takes much longer and more resources than to try to do it correctly from the beginning. So we'll go more into detail of all of these areas, but this is just a quick overview of the revenue cycle management and how it, plays out. And then the question comes up, all right, so you talked about revenue cycle management, and, I talked a little bit about who, but also how. And, of course, usually people will say, who, me? I'm not part of that. I just, I provide psychotherapy services, or I'm just a front desk person. So, it's not part of my issue. And how do I, really do this becomes a big question as well. So who should be part of the revenue cycle management? Again, as I mentioned, definitely the finance/billing department, whatever way you have organized, should be part of it. Operations should be there. The management should be part of the discussion. The compliance should be there. You want to make sure you're meeting the regulatory requirements, that your bills are accurate, that there's no suspicion of fraud, or some, wrongdoing whatsoever. So these are just some of the areas that really should be involved in the revenue cycle management. And there should be really a group that comes together in some agencies, and usually it would be referred to as a revenue cycle management committee, work group, that kind of comes together, and works on this, right? And they create tools. They're the ones that do, they measure, they create standards, they measure against standards, they document, they address problems quickly, and there's communication. And I think if anything you take away from here is communication. And I think the little, cartoon that you see here probably, in my mind at least, kind of tells it all, because as the cartoon says, what if, and I know this sounds cookie, we communicate with employees. I know that sounds, ridiculous and so forth, but if you look back and you think about it, how often do you communicate with your employees about revenue cycle management, about their ability to put in the right codes, or the front desk to do the right thing, or the registration people and the claims folks and so forth? I think the loop here to the employees is crucial. When I say document here, I think it's important to underscore, we spend a lot of time talking about clinicians documenting, and that's important, and that's, and we should spend time, and documentation in the clinical sense is crucial. However, what I think happens in the kind of the back office administrative, definitely in the billing sense, there seems to be lack of documentation of what decisions have been made, what are the processes, what are the workflow. So when we say document here, we're not talking about, in this particular sense, document, from the clinician side, again, should be done and important, But when you meet and there's an agreement and a decision made, you need to document that, because we all know as soon as you leave that meeting, you're going to forget it, or definitely 3 to 6 months. And what you don't want to recreate is that this group constantly meets and discuss the same thing over and over again, and you're recreating or trying to solve the same issue numerous times. So again, it's very important that you document this. When we talk about tools, you need to create part of your documentation and tool creation, something that you can give to your employees and others that they can use to make their jobs easier and their lives easier. So this way it reduces the number of mistakes they make, right? So if you want clinicians to use particular codes, or there's only particular codes they should be using, they should have some sort of a tool or a document that says this is the finite number of codes that you're allowable to use. If you can program that into your EHR, that's even better. But there needs to be some sort of a way you can communicate that. Sometimes that particular tool could be referred to as a charge master. But again, those are just some examples. And when you talk about standards and measuring against those standards, the group has to decide what is the standard. What would be acceptable error code? What would be acceptable denial code? You know, you also want to address problems if somebody learns of a particular issue, because things come up, you know, especially in an electronic world, but even on paper, you know, you want to be able to put this together. The other big thing here is when you have a work group, somebody has to be in charge of this work group. It doesn't mean that they're the ones who get blamed at the end of the day if bills don't get paid, because it's really the work group / committee's responsibility. But unless there's somebody who takes charge of this, make sure the group meets, that there's an agenda, that there is a deliverable, and they're on top of things. In my experience, this really goes nowhere. So again, very important that you have identified it. It could be 3 people in the group, it could be 6, it could be 7, you know, but again, there needs to be some sort of a group that meets that encompasses different area of the agency and that specifically focuses on this. So again, what we talked about, some of the key areas that should be focused on during revenue cycle management or in general, another way of kind of thinking through this, there's the eligibility component. One of the big components that has always been, especially in the clinics, but now for everybody as you know, other programs moved into managed care as well, is determining if somebody eligible. And when we say eligible, not only are they eligible for Medicaid in particular, but also what managed care plan are they part of. And this is not one-time deal, right? You do this at registration. You do it when the individual shows up. You know, you have to, I mean, again, look at yourself when you go see a doctor. One of the first questions they ask is, are you still with the same insurance company? Can I see your card? Right? So those are the key components to focus on. If a particular service you provide requires authorization, there are some services that don't, but if it requires authorization, have you obtained that authorization in a timely manner? Is it covering what you're doing? Are you scheduling? Is there a scheduling, especially a centralized scheduling system? And when we say scheduling, because sometimes agency says, yeah, we schedule, but they really mean that each person has their own little black book and they write their schedules down. When we talk about scheduling, we're really saying a computerized, centralized scheduling system. That's important to do. Registration, who handles it? How well are they trained? Do they understand how to register? What components are, you know, more important or crucial, and why things need to be accurate from the beginning? When we talk about charge capture and coding, we're going to talk about, again, and you know, my colleagues will get more into it, you know, what codes are used by whom and how. And then there's the whole claims processing and, of course, reporting and analysis that follows through here. So let's focus a little bit more, again, about eligibility, and we'll go through some of this again in more depth. As I said, when possible, insurance eligibility and benefit verification should take place before the initial visit and checked regularly. You should have staff that have knowledge, right, about at least the most common insurance plans you take, cover, and your consumers have. You're always going to have outliers. You're always going to have people come with some insurance that maybe nobody's familiar with or have very limited knowledge. But you should take, you know, you should have staff that have that knowledge. If you talk about managed care Medicaid, one of the resources, just to do a little plug here, on the MCTAC side, we have created the matrix, and so if you go to MCTAC, it can give you information, at least who to contact within a particular plan that you might not be familiar with. So again, just some resources, but that's managed Medicaid only. There's commercial and Medicare and other types of insurances. But at a minimum, again, your staff should have knowledge on most common insurances. And also another way to check eligibility besides e-PACES, again, just to say that as a big component of checking eligibility, is many payers have their own web portals or phone verification systems that you can call to check eligibility to see if the individual is eligible or not. All right. Authorization, again, may be required for some services, as I said before. You need to make sure that they are, that you obtain these services. Each payer has their own unique process for that. Sometimes it's a phone call, sometimes it's paper, sometimes it's electronic. And it's important to realize there's really two big components to authorization. One is visits and one is time limit. And what does that mean? So in the clinic, you might get 20 visits for 3 months. And either one of those that expires means you have no authorization. So for example, if somebody gives you, again, 20 visits for 3 months, and you only used up 10 in 3 months, and it's month 4, you will not get paid. And it's important to realize that even though you have 10 visits left, but the 3 month period have expired. And on the reverse side, if you used up 20 visits in 1 month, which would be a lot for a clinic, but if it happened, or in 2 months, you would need to get an authorization for 21st visit. So in either way, you need to have a tracking system. You need to track it. You need to have a report that tells you. Most places it's referred to as a tickler report that tells you when things are about to expire. And you want to kick off that process before you're at a point of where authorization has expired. You want to give yourself at least a couple of weeks to get that process through. So this way, when you are at a point of expiration, you have new authorization in place. You're either extending the time frame, you're getting more visits, and so forth. And that kicks in a whole other utilization management process in how you do that. But again, it's important that you have some sort of a way to track this, and it's part of your process. As I mentioned before, scheduling is a big component, we think, and encourage people to have. One of it is referred to kind of the medical model in scheduling. Again, it's scheduled through the front desk. You probably, again, have experienced this in your personal lives. And so it gives both the clinician and others the ability to track. It also gives the flexibility for new clients to be scheduled in or rescheduled. So if you're out of the office and somebody's calling in, the front desk individual could just reschedule you. Also, it could backfill canceled visits, when it's appropriate or when it happens. So there's a lot of benefits to having that kind of medical model, centralized electronic scheduling system in place. It also helps understand, as we talk in the next, the Part 3 series will focus more on the productivity area. You'll see how scheduling plays a crucial part in it. So that's just a little preview of the next series here. And with registration, of course, efficiently collect and record necessary information is crucial. It all starts from that part. Somebody in your area is registering clients, right? Either when they walk in, when they call in, or somebody else calls on their behalf. You're capturing their demographics, their financial information, and so forth. And it's important that it's efficient and it's accurate. And clients need to be aware of what are your fee policies and any payments responsibilities they might have. So again, if you have commercial insurance, there's potentially co-payments most likely. If you have self-pay clients, and even for your Medicaid who don't have co-payments, I think it's important to have a policy in place to say, if you lose Medicaid or there's a lapse in your Medicaid, what is the agency's policy on during that period of time on charging the individual and so forth. So it's important to be upfront with the folks you serve and make sure that they have all the information possible and that there's an official fee policy in place In a lot of agencies that I know of, there's a fee policy, and it's part of the paperwork that the individual has to sign when they first come into the agency. So I think, again, it's important that folks are upfront. So with this, I'm going to pass this over to my colleague and friend David, who will introduce himself and take us through the other part of the presentation. So David, I just passed the ball to you. It's in your court.
Thank you, Boris, and again, welcome everybody. My name is David Warsnick. I'm the Senior Consultant at CCSI and Chief Financial Officer for Spectrum Human Services in Western New York. This is what we're talking about today is a continuation of the second in the Boosting Your Money series, and we're going to continue talking a little bit of the other aspects of the revenue cycle management. If you joined us for the last presentation with Lisa, what Lisa was talking about fits into revenue cycle management under charge capture and coding. It is what type of service and their duration and how you translate the aspects of your clinical intervention into a proper claim that is claiming the full amount that is available to you. I'm going to be inviting Lisa in a couple minutes to talk a little bit more about our last presentation in charge capture and coding and looking at a little tool that might be helpful for you. But again, what we have been talking about is that how you capture the information, turn that into a claim, but grab all the information that is necessary for you to maximize your billing. When we talk about charge capture and coding, what we want it to be as standardized as possible and work within your electronic medical record or your scheduling system or your billing system to grab information without a lot of intervention. So as an example, Lisa talked a lot about modifiers, say as an after-hours modifier. Well, in most EHR systems, there is certainly a timestamp because when you schedule a visit, you schedule a visit for 6 p.m. in the evening, the system knows there's a timestamp on that service, and your billing system or your EHR system should be able to go out and read that timestamp and automatically put a modifier on that visit. The other piece that occurs is there's modifiers for MDs and nurse practitioners. So your systems know who is providing the service. Your system should be configured in such a way to recognize if that individual is an MD or nurse practitioner, and then automatically apply the modifier for those services that is appropriate and allowable to modify, because in each of those cases you are going to be billing for a higher dollar value. So many times what I find in talking with people is that their systems are either not configured correctly, or they're not fully configured, or their training has not been sufficient enough to understand the capacity and the capabilities within their billing and EHR systems. So one of the things I always suggest to people is to go back and take a look. A lot of us have our billing systems that were configured by somebody 3 years ago who no longer works for us. And we all go along assuming that our systems have been configured correctly, but they can't always be assumed that that was set up correctly. Things change, people have different understanding of the rules. So my suggestion would be is to go back and look in your EHR systems and check on your configuration. And so at the end of the day, some of those changes in the modifiers should be automatic. Now, not everybody has systems that are configurable in that way. So then there are the challenges, and Boris talked a little bit about these earlier. What system do you have in place to assure that the information that you need to properly bill moves from the provider of the service and gets into the billing system correctly? That becomes a challenge, and it becomes a challenge in two ways. Is that you know, there's a human factor in that. People forget, they don't understand, you know, and things get missed. The second challenge is, do you fully and does your system fully articulate and understand what data that you need to be able to maximize your billing? In a second, we'll show you a little spreadsheet that we put together that might be helpful to you as a visual around that. So at this point, these are Lisa's tips. So I'm going to take a second. I'm going to share my screen, and I'm going to pull in the spreadsheet that I was talking about, and I'm going to do a quick walkthrough of how you might use that, and then I'm going to invite Lisa in to join us. So I'm assuming everybody can see a spreadsheet. If not, one of my colleagues can holler out to me. It's called the Mental Health Outpatient Clinic CPT Revenue Calculator. If you had been back in working in the day that APGs were just coming online, this was a calculator that OMH had posted to their website to be used for calculating revenue through the APG conversion. We grabbed that, made some modifications to it, made some corrections to it, added some of Lisa's tips, and hopefully it will be a helpful visual for you. So I'm going to walk through a couple of things that you can do. And as Boris said, by the end of the day, this will be posted to the CTAC website. So there are a couple instructions over here. One of the key things is to be able to have this calculator work correctly is that you have to set your, rate correctly, and it looks like, oh, there it is, I'm sorry. So you have to set your base rate correctly. If we go over here to the instructions, you'll see that there are 8 different base rates that exist right now. You have your Article 31s for upstate, 31s and DNCs for downstate, and you have your county rates. These are your rates including your quality improvement add-on. These are the rates without your quality improvement add-on, and here are the hospital rates. So the first thing you're going to want to do before you use the calculator, find which bucket you're in here. I happen to be in the upstate Article 31 DC. I'm just going to do a quick copy on here. I'm going to run over to here, and in this field, I'm going to do a paste special. And you'll see now I'm working against my proper upstate base rate. So the way that this works is, and you can use this in a couple different ways, is you'll note that in each area that is yellow, you can put an input in. So let's take a quick example here of initial assessment, diagnosis, and treatment. If you provide one service, you're going to generate a revenue of $147,000. If, in fact, that service was provided after hours, then you'll see that that service will jump up to 158. One of the reasons that we provide this is, here's a CPT code here. Now, if you can go into your billing systems and pull your CPT codes, you may know how many of these you've created, but you may not be able to pull out of your system where if a modifier had been provided and been added to that billing. So sometimes what we have to do is we have to evaluate our systems not based upon what was billed, but based upon what was paid. So as an example, you're doing some of these and you're a clinic director and you know that your clinic is open in the evenings and Saturdays, and you want to make sure that you're billing out properly with the modifiers. But you can't, you get a report from your system and your system doesn't tell you if a modifier was attached. One of the things is you can eyeball, you can go in your system, you could find one of your providers that you know is providing services on weekend or evening, and you can go and take a look at that claim and see what was billed or what was paid. And if it's not 158 and it's 147, then you know that that modifier has not been added. So it really becomes a tool for you to be able to, first of all, visually see which of the services and which of the modifiers you can add. Again, if it's a yellow, it's an allowable modifier for that service. Gray is not, so you get a good feel for which of the services can be modified. And secondarily, based upon what your base rate is, it can give you an idea of what you should be billing and what you should be being paid. And the final thing you could do is you could say, okay, I've got, say you need to make a presentation to your staff because your staff is forgetting to give you information about after-hours modifiers. You could do something like, okay, staff, we did 20 of these, and we got $2,900, but we forgot these 20. And what if we remembered to put these 25? Well, suddenly the amount of revenue that we've generated goes up. So there's a lot of ways of using this tool. I like it. It's visual. It's colorful. I'd like to thank Lisa. She's our artistic director. She helps us put these in a nice, usable format. And at this point, I'd like to invite Lisa in to talk a little bit about the tips and how people might want to think about how this might be helpful for them.
Thank you, Dave. This is Lisa Clark with OMH, Artistic Director. I thought I was just here kind of for comic relief, but on our last webinar, we had a poll, and I wanted to see, because we keep giving these, you know, webinar after webinar, and a lot of you are participating on all of these. But the what's your issue is, guys, you guys are participating in the webinars, but I need you to actually follow through on the services. So last time we had a polling question, I asked how many folks were actually using the techniques from the services, and I got a 14% yes rate, and a 20% no, a 20% working on it, and then kind of about half of you were not really sure. So we continue to hope and help, and I love color coding. So this is like happy holidays here. The green, this is like bags of money. If you were on the last one, I had a tip sheet on the, like, where to super key in on how to find the money, and so we've kind of revamped the CPT revenue calculator that Dave was just presenting and then matched it up with these money tips. So if you could see right here, we'll start with like the 90, anything that's in green, this is like the easiest money possible that you guys can suddenly just pick up off the floor, I swear. You need to check and look for these codes to make sure you're using them. So the 90792 with your docs, Again, if you look up at the 90791, I have you check there and look at this stuff by your staff. You guys know who your docs and psych nurse practitioners are. If you see that any of that staff is doing a 90791, have them switch that, and just for consistency and to kind of ensure that you automate the process as much as possible, have them just do 90792s when they see new patients. It has to be for a minimum of 45 minutes. Get your system to automatically add that modifier. So you want to count and do a count of each of those services by staff type, the 90792. Then the next thing you want to do is you have to, so that other box there for the MD NPP modifier I have in green, you have to make sure you add the modifier on there, or you're not going to get paid the right amount. Dave, if you change that to a 0, show them, you'll just get paid the 147 there. So check the amount that you're being paid. If you look at kind of those orangish ones, you will see the E&M codes for all 3 of those. While they look like they're kind of 3 different services, you can see by the E&M codes they're really the same. Where you make your money, and the difference here and how much time your doc is spending is whether or not you're using the add-on codes. So in your system, if you're able to just do a count of the 90833 and the 90836, over here on the side on the money tips, we have count these codes, and then kind of there's like a note there on what your expectation should be. And this will, you have to align this with what you know your docs do. Rarely are there places, but occasionally there are some where every appointment is for 15 minutes. But if you know pretty consistently your docs are spending 30 minutes, 45 minutes, these codes, the count on these units should kind of align with what you know the general practices are. Crisis intervention, H2011, and just I'm going to throw this in here because someone asked and mentioned last time a comment on managed care plans that are denying these. The H2011 does not indicate whether or not it was by phone or face-to-face. It's the same exact code that you use for both of those services. So unless someone came and read your note, they're not going to know how the service was provided there. But make sure pretty much all staff at some point in time during the course of the year should be doing and providing crisis intervention, and it can be by phone. Check, see if it's there or not, review this with staff. These are things last time we recommended that you review with staff, some of this in supervision just to see. So it's not just where you're discussing productivity measures with them, but you're actually looking at like the service distribution of the types of services that they're delivering. If we hop down, we're just kind of doing the heavy hitters here where you can really make some money. Complex care management, go back, review what that was if you're not sure, but I want to look and do a count of how many units of that. All of your staff is spending follow-up time on the phone. It can't be regular and routine. Reference what's in the 599. There's a really good FAQ section on the OMH website for that. Have some, present it during a staff meeting when it's appropriate to use it, how to document it, and then look and see how many of your staff. That's for 5 minutes of time, that $14 right there. So you could do 4 units of that in response to a particular issue that someone is having in order to stabilize and provide integrated care. Easy money, guys. Such easy money. You just have to make sure you remind your staff to use these things. If you're a kids clinic, I'm sure there are plenty of times where you've spent an hour with a parent and a child for a visit. Make sure that your staff is using that 90847. If your doc or psych nurse practitioner enters that session for 15 minutes for any reason, remind your clinicians to indicate that and add that modifier. However, you need to translate this into steps that apply to your system and your EHR and how you make these things happen. But go over it with them, remind them, note it. The doc or the psych nurse practitioner needs to sign the note. They don't have to write the note. So the clinician can write 1 note, but you need 2 signatures to document that. If you have bilingual staff, check and see, as Dave said before, if you're using the U-form modifiers, and if you're providing you have to provide services after hours, not just be open. I had another question that came up about that. So if your clinic opens at 8 a.m. but no one's providing any services, there's no way to, there's nothing to add a modifier to there. And in this case, the after-hours modifier is really its own CPT code, which is the 99051. So count those if you know you're open during those times. And I'm going to flip this back because there's a lot more to cover here.
Yeah. All right. Thank you, Lisa. This is Boris again. And David, I just wanted just do a time check since we're at 12:45. Yeah. Okay. We want to leave some time for Q&A.
Okay, so let me stop sharing my screen for 1 second and get back over to here. Okay, should be back, so let's move through this more quickly. I did want to spend a little bit extra time on that model. I think it might be very helpful for folks. So some of the things that we've talked about already, type of service and duration have to be grabbed. Try to standardize your charge capture and coding, build your systems, and make sure that your systems are configured in such a way, have a process to assure that information gets passed along to billing properly, and then if it's a manual system, audit it. Take the worksheet that we saw, figure out what you should be being paid if you can't get your modifier. Go into your systems and make sure that you're getting the proper information. Audit and quality improvement are a critical component of the revenue cycle management. So in the claims process, claims go out the door in different ways. You can certainly do it directly to the payer or through a clearinghouse. Part of the conversation we have about keeping the money is that the claim's got to go out, it's got to go out correctly. It's got to stand up to audit. It's got to be able to, it's one thing to get the money in the door today. It's another thing to have OMINT come in and force you to give the money back later. So you really need to have a system where you know the documentation is complete, it's proper, the note on the note absolutely it ties back to the billing. These are normally a lot of these aspects can be built into your EHR system. I know, and if you're thinking of other systems, one of the things you may really want to key in on is how does the clinical documentation inform the billing? That is does the system know that a treatment plan was not signed, so it keeps the claim from going out the door until that problem is fixed? Or is there a bill that's going out the door for a service that was not on the treatment plan? A lot of systems can be configured in such a way that the clinical documentation informs the bill to assure that the bill that's going out the door is in fact consistent with the documentation and the documentation requirements. Claim processing, and Boris talked about this. Every time you got to go back and touch a claim for improper formatting or even for being suspended, it takes time, it takes energy, it takes money, and you have to work hard to get that money back. So you may get it at the end, but it costs you more to be able to receive it. And we've talked these other ways of scrubbing claims. If you work with clearinghouses, they might do a good job of scrubbing the front end, make sure your bill's formatted correctly and out the door, but your clearinghouse doesn't know if your documentation supports the bill. Reporting and analysis is that, and I talked about, part of your process should be quality improvement. The only way you know about quality improvement is that you have some metrics that you would use to be able to determine if your system is working properly. We talked about your aged accounts receivable. This should be able to give you an idea, first of all, is if you're billing in a fashion that is consistent and regular? And second, are your payers paying you on a timely basis? So this sort of serves two purposes. It serves a front-end process purpose to understanding what the timing is on your bills going out the door, and it also serves a purpose to understand how quickly your payers are paying you. The collection ratio. So you send 50 claims out the door. How many claims came back paid? So are you sending claims that are incorrectly formatted, that are being rejected? So understand what's going out and what's going back to see if you've got a problem in your system. A denial report. One of the key things that we see is denials due to lack of authorization. So do you have a good system on your front end to assure that you're providing services to individuals who you will be paid for because they are eligible under the insurance that you're going to be billing? This, if I had to suggest that you get one report up and running, and the next month, if you don't have it, would be your denial report. And then the final piece here we talk about is errors in claim report. What's getting suspended? Why is it getting suspended? What's getting rejected? What are your errors? The only way you can fix your system is you know where it might be broken. And finally, the process. You need to formalize your process. You need data. You need to use analytics. You create solutions, implement change, measure the results, and then if it's not fixed, go back to it. So the key, again, one of the key components in understanding your revenue cycle management, your ability to keep your money, is how well is my system working, what are the metrics that tell me it's working well, and how do I fix it when I figure it out. You've seen this before. These are the healthy clinics back in 2013, 44%. You increase your revenue by 15%, and that goes up to 65%. It makes a big difference. So I'm sorry, we moved through the second half pretty quickly. The webinar will be online and by the end of the day, along with the calculator. So we have a couple minutes for questions. Boris, you've been monitoring those, so I'll let you go.
Great, thank you, David and Lisa again. And we do have a number of questions that we want to get to, so thank you for sending them in. And again, for other folks, if you have questions, please chat them in through our chat box. But let's jump right into the Q&A portion of this presentation. So the first one we have is really about the HCBS services, and just to emphasize and again to clarify, this presentation is for Article 31 mental health clinics only. So all of these modifiers that we talked about, in particular CPT codes and billing codes, are Article 31 clinic rules. So any medical add-ons and everything else, you know, might or might not apply to other programs, but today's presentation is only for clinic, especially when we talk about modifiers and add-ons and so forth. However, some of the processes like revenue cycle management and some of the reports are applicable to all healthcare billing, really. But so I just wanted to, because we had a question about HCBS and can with medical be part of it, and that's outside of this presentation at the moment. The next question was, how do we know if we qualify for the quality improvement data add-on? I'm sorry, and Lisa, I think you have an answer for that?
Yeah, so if you go to the OMH website, and at the bottom you can go to clinic, or you can always just type in Google, because Google knows everything. But once you get, there's a page, Medicaid reimbursement rates, and under clinic, there's provider-specific base rates, so you can look up by agency name. And just to further clarify Boris's last comment about who the audience is for this is not for OASIS clinics. And for OASIS providers, again, some of these concepts may be applicable, but we do not have any, you know, direct knowledge of that, so we just want to be clear that we're not misrepresenting anything.
Thank you, Lisa. And that was our third question from an OASIS provider about that. So as Lisa said, no, again, these are very specific to mental health and OMH clinics. What is the criteria for after hours? I think it's in the presentation. It's actually on the Excel spreadsheet or the tool that David and Lisa went through. I believe it's the after hours are before 8 o'clock in the morning and after 6.
After 6 p.m. So a service must be delivered before 8 a.m. or after 6 p.m. So if you start at 6, but if you start at 5:30 and it goes to 6:30, that's not after hours. It's when that service starts, and also on the weekends.
Right. Great. Thank you. For clarification, when a doctor and therapist are in a session with the family at the same time, both signatures are needed in the EHR? I believe the answer is yes.
Yes.
It doesn't have to be 2 different notes. Of course, it could be 1 note, but both signatures are required, I believe. Correct, Lisa?
Correct. So that, and Boris was also pointing out to me, whether or not your EHR has the ability to accommodate 2 signatures, that's kind of on your end, or if there's an adaptation, or whether you need to do 2 separate notes because you don't have the ability. But.
All right, thank you. The next question we have, must a 90792 be provided as pre-admission visit, or is it okay for the social worker to conduct the first session as a 90791, admit the patient, and have the patient see by MD for 90792? I believe the answer is yes, but I'll turn it to Lisa.
Yes, so the short answer to that is yes, and I'm going to suggest if some of the questions are along those lines, go to the CTAC website, and in the training search tool, if you type in my name, Lisa Clark, it will pull up some previous revenue maximization and another boosting your bottom line webinar that goes into more detail about those specific types of assessments.
Right, thank you. We have another question. What are some tips for projecting accurate revenue for clients in commercial versus managed Medicaid? Since each company pays differently, does that spreadsheet allow you to calculate revenue? I'm going to really turn this to David and Lisa. I think that is really for managed Medicaid because the rates are preset as managed Medicaid rates. As individual pointed out, correctly, commercial companies, you negotiate rates. There are different rates by company. They don't necessarily, and a lot of times don't match what Medicaid pays, and also on the commercial side, based on your contract, the modifiers might or might not be appropriate. So that really spreadsheet is geared towards managed Medicaid. But again, David, Lisa, anything else to add to that?
No, Boris, you're correct. It takes the CPT rate and multiplies it by your base rate, which is the way Medicaid Managed generates your rate. That is not a methodology that is necessarily used in the commercial policies. So you really have to go back to your individual contracts. This would be a difficult spreadsheet to modify to be able to manage all those variables.
Right, especially when you get past 5, 6, 7, 8 managed care companies and onwards.
Which all of them, it's really designed pretty exclusively for the your Medicaid population.
Great. So that's the questions we got so far, and we appreciate those. We're going to give it another 30 seconds or so to see if there's any additional questions. But we, again, appreciate folks sending those in. We hope this was helpful. And as I said, after New Year's, we have 2 more sessions for this series on boosting your bottom line, and we hope that you guys can join us for those 2 sessions as well. And before we sign off, let me see if Lisa and or David have last-minute comments.
Well, I was going to say, since we have a minute here, I had some questions from the last webinar that we could just quickly answer. Someone had asked if you could bill the after hours for holidays, and so holidays aren't covered under after hours, so you could only use the modifiers, as we said, before 8 a.m., after 6 p.m., and on weekends, because there could be some, who's defining what constitutes a holiday would get complicated.
Great. All right. David, anything in your end as we wrap up?
No, I think that we're good. As you mentioned, we have 2 more presentations. We're going to be addressing productivity and many different ways of thinking and reporting on that. And then we'll have a series on dashboarding, which would hopefully give some people some additional ideas about reports, report formats, communicating, and Boris, you talked earlier about the importance of communication. You know, how can you grab your data? How can you put it in a usable format? What's important for you to be looking at? And how do you communicate in a meaningful way and then use your data to drive some of your decision making? These are all aspects of what you need to be doing as part of your structures to assure that you can boost your bottom line. So I invite everybody to be joining us. There'll be more information out. Thank you for attending today's webinar. As you can see on the screen has been our website information. Again, the PowerPoint and spreadsheet will be on the CTAC website by this evening. The recording of this webinar will be probably out by the end of the business day tomorrow. So if there's nothing else, we thank everybody for their time and attendance, and hopefully we'll talk to you sometime in the new year. I hope everybody has a great holidays and a happy new year, and you'll join us again soon. Thanks, everybody.
Great. Thank you.
Thank you.